Let's talk about feeding tubes. So, per usual, I'm in the outpatient setting. I own a private practice. So I see patients after they have moved through an acute medical event, injury, experience. There are several kinds of feeding tubes: a nasogastric tube, a PEG tube, a J tube. Today, the stats I'm going to talk about and the info I'm going to share is primarily about PEG tubes, percutaneous endoscopic gastrotomy tubes. So, a feeding tube is placed to provide nutrition and hydration when somebody can't tolerate it all by mouth. That is its job, that is its goal. We kind of willy-nilly put them in occasionally, or from what we see in our perspective is we get them, a patient makes it into the world, out of the hospital, and we don't know what to do. A feeding tube, statistically, 7 out of 10 will require additional medical attention. They get dislodged, they get clogged, they get infected. A feeding tube, statistically, does not prevent the onset of aspiration pneumonia. The likelihood somebody is aspirating their secretions, which contain the kind of highly active oropharyngeal microbiome that facilitates the onset of pneumonia, is what causes pneumonia. A feeding tube also, the aerodigestive tract is a pressure system. When we poke a hole in a pressure system, we see that there are negative consequences. When we put a feeding tube in, statistically, we see a pretty significant increase in reflux of gastric content. That PEG puts back pressure on the lower esophageal sphincter, which sends stuff up and through the esophagus, bothers the upper esophageal sphincter. Often for our patients who are also NPO and still experience the onset of pneumonia, it is very likely that if that patient spends time in a supine position, it is the gastric acidic content that they have aspirated, because that's about the worst thing we could put inside of our respiratory system. Refluxed gastric content is incredibly caustic to the respiratory system. Feeding tubes also place a pretty significant burden on a caregiver. So we see that a caregiver who may have a significant host of other responsibilities now is in charge of flushing it, looking at it, making sure somebody's helping them with it when they need it, feeding that patient. Now don't get me wrong, there is a time and a place for a feeding tube, but we also know that the American Geriatric Board of Medicine and the Alzheimer's Association both have position statements out against the use of feeding tubes in the Alzheimer's population in the end stages. So for anybody looking for additional information on any of this, I would be happy to share it. You can message me or email. This information is pretty readily available. Feeding tubes, again, provide our patient an alternate place for food and liquid to be put. Feeding tubes aren't also mutually exclusive. Just because we have a feeding tube doesn't mean that we can't eat and drink by mouth and respectively supplement when we need it later. But a feeding tube is not going to prevent aspiration pneumonia. It is not going to prevent aspiration of gastric content or aspiration of secretions. It is not statistically going to improve quality of life or longevity of life for individuals in late-stage Alzheimer's, and can be kind of a problem. So when we talk about placing a feeding tube, we gotta be thinking of the negative consequences outside of the immediate medical event that may play a much, much bigger role than our pretty quick time in the hospital. All right, let me know how you're talking to your patients about feeding tubes. Let me know how you're using them.